This week on the BackTable podcast,
I think setting up champion groups like that, especially on the physician side, is so important. And I think that's one of the things that has made our last 2 years of rolling these solutions out successful is because of physicians like you who are willing to come along and be the guinea pig and kind of have some of the heartburn along the way while we try to figure the solutions out. And I think you and the other ones in the group, you also have an understanding, and I'd like to make this a broader thing. And I try with talking to the physician groups and stuff. There's a lot of potential here, but there's a lot of things we have to work through to get to the potential. And I think you and others have that understanding. So it's really nice to be able to give you sort of a little bit of a raw product and say, tell me how to make this better. Tell me how to make this fit you and your workflow. And I think that's really important. That's probably the most important, if anything.
All right, well, welcome to BackTable Tumor Board. Really excited to be with my friend and colleague, Larry Bilbrey, today. I'm Kate Baker. I'm a medical oncologist at Tennessee Oncology, and excited to have this conversation around AI in oncology. I think it's such a hot topic these days. But Larry, why don't you start with introducing yourself and just telling us a little bit about your role at Tennessee Oncology and OneOncology?
Yeah, thanks for having me, Kate. I appreciate it. Glad to have an opportunity to talk more about AI. My name is Larry Bilbrey. I do run the digital innovation arm for OneOncology, which is just a fancy way of saying AI these days. I think it was before you could justify putting AI in a title. Yeah, you had to come up with like a way to oh, he does more than just AI, right? And so I had digital innovation for OneOncology, and then Tennessee Oncology, I run the data and insights department as well as digital innovation for Tennessee Oncology as well. I've been with Tennessee Oncology. I'm on my 20th year, so been doing this for a long time. Started in operations. I was a regional manager, had several clinics under me for many years, and then right before COVID started, made the switch over to data, and then just sort of that was 2019. So that was right before the AI bubble hit, and through my sort of data learnings and trying to wrap my head around all things data, I saw the train coming with AI, and I was like, well, I probably need to familiarize myself with this. And so I just started diving headfirst into AI. And I do want to say also, I've said this many times on many different stages and stuff, I am not an expert. So sometimes I get billed as an expert in AI. I am not an expert. I just was maybe one of the first ones to the table. And so I just have experience, and I've learned the hard way. So I'm able to share experience, not so much expertise. So
You're an expert to me, Larry.
I appreciate it.
Well, I mean, I think that's a good jumping off point. I feel like every single conference I've been to has dozens of AI sessions now, whether it be ASCO or COA or any of the other conferences. So what's fundamentally changed over the past, say, 2 to 5 years that makes AI different from previous waves of healthcare technology?
Yeah, I think this is the first technology that we have seen outside of drug approvals and stuff like that, especially in oncology, where the technology is going to make an immediate impact. The last one that we saw, in my opinion, was the cell phone, the smartphone in 2009 when the first Apple phone came out. I think that, before that, physicians were all using pagers, and that's how we reached the physician when they were in the hospital. And then smartphones came out, and also you can text them as a game changer, right? And to me, that was the last time that we saw a technology shift that impacted the way that we fundamentally did something in healthcare overnight. And so I think this is that next one that is changing the way that we do things overnight. Now, I do think the promise of AI has made us dream really big. And so I think everyone in the world is sort of envisioning this world where AI is the doctor and making the decisions, right? And we are years, decades even maybe away from that. I don't think, your job is safe. Doctors aren't going anywhere. Yeah. Doctors aren't going anywhere. And clinicians, I think, are safe too. The robots are a long way away from being able to stick a needle in an arm to give chemotherapy, right? But I do think from a workflow standpoint, from anything that you can build an algorithm of, or anything that's done just solely on a machine, AI, we can inject AI today and make a meaningful difference in those processes those resources that we need in order to get those tasks done. So, and we're already seeing that. I know you use a lot of the AI tools here. You use the scribes, you use some of the workflow overlay tools that help present data to you so you don't have to go digging through the chart, right? So I think we're seeing a lot of evidence in that across healthcare and oncology. So yeah, I think it is set to make a big impact. It is already making a big impact, but more so on the workflow side, not so much on the replace doctor side.
Yeah, I totally agree with that. I think we're a long way off from the technology being able to replace a doctor. And even still, there's still a human side of medicine that I think is pretty irreplaceable, or I hope is pretty irreplaceable, although maybe I'll be changing my tune in 5 years. Who knows? So I think we've touched on workflow integration and that sort of thing. Does AI eventually become sort of like this invisible part of our workflow as it touches like every part of the system within oncology? Or do you think it's still going to be very much this like visible like tool, like analogous to like a smartphone or an EHR?
I mean, I think it already is in our day-to-day life, right? ChatGPT, Claude, I think I won't say everyone, obviously I don't want to generalize, but I think a large percent of the population is already made, well, even the ones who aren't physically pulling up ChatGPT and typing in a prompt to get an answer, they probably don't even realize that they're using AI on a day-to-day basis. If you're going to Google to search for something, Google's already got Gemini and all of its search engines, right? Because when you type in something, the first thing you get back is that little AI summary, right? And so if you have a iPhone, right, AI, Siri, it's already on there. So yeah, I do think it's already it's here, it's embedded, it's everywhere. I think the foundational companies, the Microsoft, OpenAIs, the Metas, their original task was to collect as much data as they can, train the models, try to get them better. And I think we consistently see these improvements, every couple of months, each model comes out with a new version and, and then supposedly better than the previous one and cost more. And then, a couple months later, a new one comes out. And so we keep getting a lot of improvements. Most of those seem to be focused around sort of day-to-day assistant type of work, right? And so I don't think it's very different than how we're using it in healthcare either. We have tools out there that are pulling in NCCN guidelines and different publications and trying to get you that information without you having to go and Google certain things or go to certain tools and type out a whole bunch of very specific diagnosis and disease information just to get the correct information back. There's AI tools that exist today where you can give a pretty generic high level view of a patient and get a response back from the AI like, oh, well, here's, so we give a good picture of what NCCN says, and here's what New England Journal says, or studies that have happened and things like that. So yeah, I think it's embedded. I think it's here. I don't think anything's happening with it. So
are there particular parts of like the system or the workflows where you think AI is like particularly positioned to improve upon what's existing? Like, for example, is it scheduling? Is it genomic testing? Is it patient education? Is it triage? Like what parts of the workflow, or maybe it's the entirety of it, do you think that AI is particularly helpful?
I think there is hope for all of the above. Like you name it, again, with the exception of that physical sort of, holding the patient hand, putting the IV in the arm. I think there is the promise that AI can help us with all of that. Now, I do think there are levels to it though, right? Because I'll use triage as an example. Could AI do a pretty good job triaging? Yeah, it could, because it's algorithmic, right? We could give it very clear guidelines. If it's nausea and they have it at this frequency, and check and see if they're taking compazine or whatever. If they're not taking compazine, X, Y, and Z, right? Like we can give it very specific algorithms. But I think there's sort of two issues that we haven't overcome yet that we still, in a lot of areas, clinical areas especially, are going to be a challenge over the next few years. So the first one is the most obvious one, and that's the accuracy level of it. And AI might be 90% accurate, might be 95% accurate. I was actually sitting in a meeting, and I won't call anybody out or anything like that, but I was sitting in a meeting with the top AI companies in the world. And when I say that, I'm talking about the top ones. sitting in a meeting with their engineers. I was fortunate enough with some of the different organizations I work with to have an invitation to this meeting. And a statement was made in that meeting that said, we have to accept that AI is going to kill a patient.
That's pretty terrifying.
Yeah, right. And I think that I understand what they were trying to say is that AI is going to make a mistake that's going to cost someone their life at some point, right? From a healthcare standpoint. And they had also made another comment about 90% was sort of the bar. Like if we're over 90% accuracy, we should feel good about ourselves. And I sort of let them all talk, and I finally spoke up and I said, listen, guys, I hate to be the Debbie Downer of the room, but two issues with things that you said. One, you said 90% is good enough. And that may be true in the automotive industry or in the restaurant industry. That may be great. 90% is amazing. If my ChatGPT was 90% accurate when I was asking it questions, I would be head over heels, right? We're talking about healthcare. We're talking about making, especially in oncology, we're talking about life and death decisions, right? And 90% is not okay. Like nothing less than 100. Now, can we get to 100? Maybe not. Maybe that's impossible. But should we be working to get to 100? We absolutely should be working to get to 100. So that was the first comment I made. The second comment says, I have a fundamental issue with the statement that we have to accept the fact that AI is going to kill a patient. I said, we absolutely don't have to accept that. We should actually work and do everything we can to make sure that AI doesn't kill a patient. And if it happens, we address it. We do the processes to figure out what the gap analysis, all of that stuff. We do all that. We try to close those gaps. There's a lot of legal on who's going to be responsible, and we may get into that today later. But anyway, I just brought that up. So all that to say is that I think that's where we are with triage, is that I don't know that legal and compliance, or physicians for that matter, who it's your license, it's your malpractice insurance, right? That's on the line as of right now, because we don't have that case law or any of that precedent set yet on who, if AI does make a mistake, who's responsible. So right now, if a mistake happens with a patient, it's on you. It's on your license. It's on your malpractice, right? And so I don't know that culturally, from a legal and regulatory compliance perspective, if we're quite there to turn AI on something as important as triage, right? Rescheduling, we could do that because there's no harm that's probably going to come to a patient. We'd make sure we put plenty of human in the loop fail safes in place to make sure no one fell through the cracks. But, I think that's a phone engagement like that is something we would feel better about from a legal and compliance standpoint. So that's problem number one. Problem number two is also a cultural issue, I think, and that is that both sides, being the patient and the clinicians, are accepting the fact that AI is now taking a part in their care, right? And so we've done a pilot where it was an after hours pilot where a patient would call after hours. Of course, our clinics are closed. Normally go to the on-call service, which is just an IBR, right? Like a recording, if it's an emergency, press 1, and then it leaves a message for the doctor on call. If it's not an emergency, press 2, it leaves a message for the practice to check the next morning. So, my sort of idea was like, well, could we give the patient a way to interact with someone, like resolve things instead of waiting for the clinics overnight? Can we, and I'm going to use the word triage, not symptom triage, but sort of like what's the level of the call triage to determine, does this need to go to the doctor? Can it go to a nurse? You're right. And so,
because sometimes patients don't know.
Exactly. A lot of people think everything's an emergency, right? And to them it is. I don't want to minimize what a patient's going through, right? But it may be something that a nurse on call could easily talk them through how to use their Compazine, for example. Again, that knowledge of a patient that calls, and maybe we don't need to have the doctor be involved in that. And so the idea was, can we have AI sort of help triage that level of the call? Like, this goes to the doctor, this goes to the nurse, this will go to the clinic. And one of the things that we sort of realized was the cultural side, the acceptance side of it was actually really difficult, both on the clinician side of like, hey, we're not really comfortable with where this is intervening and everything. And then also the patient side, and the patient side wasn't as bad but anyone who was uncomfortable with it, we want to make sure they feel comfortable. And so we had a lot of patients that were, before, if they called, it was just a recording. Hey, choose one, leave a recording. They actually had someone like, oh, Tennessee Oncology, how can we help you today? And they immediately kind of realized something's off. doesn't sound exactly like a human. And so they immediately were like, can I talk to a human, or customer service, all the things we already do when we call like Verizon or something, and we're trying to get past the IVR. So yeah, so I think that's the other part of AI in these clinical workflows as well, is I don't know if we as humans, whether whichever side we're on, I don't know if we're quite ready to say, yep, AI is ready for this.
Oh, totally. I've had some really interesting conversations, using an ambient scribe with my patients, disclosing that. And I've had some really interesting conversations with my patients about AI. And I think I agree, as humans right now, there's still some cultural shifts that need to happen before AI is like more fully integrated into workflows. So, well, here's an interesting question. I'm actually really interested to get your perspective on this. So as we think about the EHR and how AI can overlay or work within the EHR, does the electronic health record eventually just become a database, and then AI becomes the primary interface between, I think this is long term, right? But does AI eventually become the primary interface that the clinicians and the patients actually interact with?
So that's a super hot take, and I'm very proud that I feel like, oh my gosh, Kate actually pays attention like to things. Yeah. I agree with that take. I do think the EMR, Epic might be the one exception to this, only because I think Epic, long before AI, saw the writing on the wall that they needed to control their entire ecosystem, right? And so Epic has an entire development shop that is designed around all these add-ons that need to happen for Epic. And so not EMR specific type functionality, but faxes and HIEs and things like that, right? And so as AI has developed, they've sort of adopted that same philosophy for AI. Well, if we're going to have a scribe, we're just going to build it ourselves. Right. And so I think Epic will sort of longitudinally, they'll be in that space for a while because of that extra development. But I do think a lot of EMRs that are just sole EMRs who aren't invested in AI are going to become the source of truth. And we will always need the source of truth. We will need the regulatory layer, the legal layer, and that's what the EMRs will be. And I agree with you. I think that overlays or sort of more user-friendly systems will become what all the clinicians are working out of. And so today, where you pull up a patient EMR, you would just pull up the operating system that we build, and it'll have all the information in there that you need. It'll be curated and customized to you specifically, right? Like, so your view is going to be very different than Dr. Payton's view or Dr. Shipley's view, and so I think that 100%, that's where we're going. And AI is going to be, I don't know if it'll be AI per se, like it'll probably be software companies that are just have AI heavily embedded in it, right? But it'll be AI powered for sure.
Yeah. Well, I look forward to that future. I think the customizability of it and all of that is just going to make it a lot easier to extract information. So I think that's one of the biggest challenges as a physician, is we have all of this information, right? Not only like the patient information, but also like whatever trials that have recently come out. And, especially within oncology, everything's changing on a daily basis. And so I think the future ability to overlay these AI tools to seamlessly integrate, the patient information as well as the information we need to make the right decision for the patient is going to be immensely helpful.
It will be. And I think this is a really important point. And I talk on this a lot too, because I really believe it. And I should say we, Tennessee Oncology, OneOncology, we are adopting the provider first approach, meaning that we really want to improve the provider's experience, day-to-day experience. AI, I think, is a huge part of that. But so much of what providers do now, what has become from, 10 years ago even, is just so much paperwork and just checking boxes and, making sure you do X, Y, and Z and getting emails and clearing out inboxes, right? It's all being a physician is you're an administrator, right? Like there's very little of your time do you actually get to spend making eye contact with the patient anymore. The ones that take their laptops in the room or, type the stuff on their laptops, the ones that aren't are trying to figure out how do I take notes to make sure I can get this, I remember this when I go back to my laptop. And so I think that by taking a provider first approach and trying to improve the provider experience, and, I think scribes are a great example of that, taking that need to have to consistently type notes or take notes on paper so that you can get in your note. You've got that recording that's happening. You can actually, you can kind of relax. You can look at the patient. You can have a dialogue with them, right? And I think things like that automatically raise the bar for everything, right? It's going to make patient care better. It's going to make their provider experience better, should make the practice overall because of those things, kind of the rising water raise all ships thing, right? And so that's how I sort of view this. And so agreed, if we can take these overlays and we can make sure the physicians have everything that they need in that one sort of snapshot that they pull up instead of having to, click through pages and pages of documents and all that stuff, we take a 5-minute, sort of, and this is no knock on any physician. This is just the nature of so much data, a 5-minute mediocre chart prep to a 3-minute amazing chart prep that you feel really prepared of everything that's going on with that patient, walk in the room and have that meaningful conversation with them.
Absolutely. And like to your point on AI scribes, I also think that so I know that there's some like controversial data out there to say it doesn't actually save physician time. But for me as a user, I feel like it has improved my documentation a good bit rather than just like having like maybe a 3-word HPI. It's, sentences of the stuff that I actually talked about with the patient. And then I can more accurately capture our assessment and plan based on that as well.
Yeah. So 2 comments on that. And on the data side of my world, I learned years ago that we do work in science, we work in healthcare. And if we're putting drug data out there and we're looking at drug A versus drug B and median survival and progression-free survival, some of those data statistical significance makes a lot of sense. The p-value, all of that, we need to know that, try to get it through the FDA. I'm not taking away from the relevance of that sort of statistical analysis around that type of data. But when it comes to the scribes, for example, you said there's sort of controversial data about does it actually save the physician time? There's been publications in New England Journal and JAMA recently that it doesn't really add any additional RVUs or anything like that. This has always been my stance. My question is, does it feel different, right? That's what's important, especially on an operational side. I might not be able to show you a graph where, oh, look at this great improvement or look at this great reduction and, whatever. But if I go to you as a physician and I'm like, Kate, is this scribe helping you? And you're like, man, this really does. Like, it just makes my day so much easier. That's what matters, right? And that goes to the second point that when we're looking at these solutions, there's 3 things that I think about. 1, does it generate revenue? Which that's a tough one. 2, does it generate savings? Again, it's also tough, especially in the AI world. But the third one, which I think is where we are right now, is it change the quality of life of the end user? And so that's what I think scribes are doing. There's maybe not a lot of data to support it for those first 2. Is it generating revenue? Is it saving? But again, if you guys who are using it feel like it is helping you, then that's important.
And I do think the data, like what's been reported out in JAMA and New England Journal, has shown that physician satisfaction has significantly increased. And so, to your point, I think that's what's making a real difference.
And going back to my point about the physician first approach and improving the physician experience, physician like surveys and improving those survey results, that's 100% a metric that we want to focus on.
Yeah, absolutely. Well, as we're talking about, the physician and the provider, I think something that you alluded to earlier and one of the other, big controversies or questions in the field is, who is going to be liable now and in the future, around these AI tools? What's our duty to, tell patients when we're using these tools, either for clinical decision making or, ambient scribing or, in whatever capacity we're using them? Those are 2 separate questions, but would love to hear your thoughts on that.
Yeah, this is a really complex and complicated space right now. And you've got the states sort of are different, right? Like what's happening in California is different than maybe what's happening in New York, is definitely different than what's happening in Tennessee, right? Like we're talking very different sort of focuses by the legislation. So I think that there you've got that sort of wrinkle that makes it tough. I think the other piece of it is we don't have a lot of, and no one wants to be the one on the bad side of this. We don't have a lot of case law on this yet either, right? Where something has happened bad with AI and it's gone to a court, a federal court or whatever, and there's been some sort of precedent set in case law. I do know, sort of our responsibility. I think there's two. There's a legal responsibility, there's ethical responsibility. I think everyone has to pick their own path for ethics. I'll just use Tennessee, for example. It is not required by law for us to tell a patient that we are recording their visit, in a scribe. That Tennessee is a one-party state, and so it's not required by law for us to do that, right? However, we made the decision ethically that we want to be transparent with our patients, right? And so we put in a process that whenever you as a physician goes into the room, you bring that up. Hey, I'm going to use a scribe on my phone. Are you okay with that? And if the patient objects to that, then you don't use it. And my understanding from most of the physicians across the network that very few patients have really ever objected, because I think once they see how much it frees you up to have a real visit, they again, going back to that rise in, waters raise all boats. I think that they are going to reap the benefits of having that in the room as well. So I think there's that ethical side of it. And then legally, AI made a recommendation to you, and I know we're not quite there yet, but I think that's where we all think medicine is going. And you took that recommendation and you didn't do your due diligence to say, yes, the AI was right. I think and I'm not a lawyer, I should preface this, but just the way that I've seen the conversations happen, I think for now, it's on you.
Yeah.
Right. I know when I do the contract negotiations with the vendors, it is very tough to get them to agree to certain types of liabilities, certain types of accuracy metrics and things like that. So these AI contracts do have huge liability floors on them from a data breach side, a lot of protections that we try to put in areas where we can kind of force that.
Yeah.
But it is very hard if you want the solution and the AI company that the vendor is not willing to commit to a 95% accuracy, for example, then that puts the burden on us to make sure that they're accurate. And so one of the things that we're doing at the Oncology level, and we're also doing at the Tennessee Oncology level, is we're putting human in loop audit processes in on every single AI solution that exists. So this is the scribes, this is the overlay tools, this is the faxing tools. And basically what's going to happen, and I think this also alludes to another point we can get to, and that's about replacing jobs. But what's going to end up happening is we're going to go from this group of people doing X, Y, and Z, and AI is going to replace their jobs because everything they do is kind of algorithmic and on a computer, and replace it. Well, what we're going to replace it with is this huge team of humans that's going to have to audit the AI, or a huge team of humans that's going to have the knowledge on how to get in and update the AI and make changes to the AI, right? So when I get asked that question about replacing jobs, my answer is always, I don't think it's going to replace jobs in the way you think it is. Is it going to replace specific tasks that maybe are job related 100%? But is the job market going to shift where, if there's 1 million jobs today, after AI, there's going to be 500,000? No, there's still going to be 1 million jobs. They're just going to be different jobs, right? Anyway, so going back to the audit piece of it, our responsibility to our patients, to our partners, to anyone who has any stake in the company or in the safety of our patients, our responsibility is to make sure go in. Usually our policy right now is we do 100% audit and on the front end. So that means every single thing that's happening with AI, we have a human going behind and checking to make sure it did it right. Once we get to a certain service level that we feel is good, which, as you already heard, my bar's pretty high. I want it to be 100. I know that's probably not realistic, but depending on the solution, like for faxes, I can accept 95% accuracy, right? And so that's our bar for faxes. And so if we show consistent 95% accuracy on faxes, then we'll taper it down and we'll do samples, for the next 6 months. And then when we still are seeing the same level of accuracy, then we'll taper it down even more and get to sort of a more routine annual review or something like that. There is something else called drift that I don't think a lot of people understand as well. It probably terms people have seen, but this is also something that we have to watch for with AI. So you put an AI in place today and it works really great, but the softwares that it works on, so the EMRs or the databases or even the drug information, the algorithms change over the next 1, 2, 3 years. Is that AI solution evolving and updating along with all these changes that are happening, right? Because what is working today may not be working in 1, 2, 3 years, right? And so we have to monitor that. Is the AI still relevant for what we're doing? Is it keeping up with the questions that we're asking it? Is the data model that it's trained on so old that we need to sunset it and we need to bring in a newer model in order to be able to answer these questions? So that's another thing that we have to keep an eye on that I don't know that a lot of people are thinking about these days, because AI is so new, right? And this is no knock on anyone. Again, I'm not an expert. I don't know anyone that's an expert right now because it is all so new. We're all learning the hard way how to navigate this. Like I said before, none of us want to be on that bad side of the lawsuit. So I think we're all just doing the best we can, trying to make sure. Yeah, and we're learning, but yeah, we do have a huge responsibility to, like I said, to our patients, to our partners, to our staff, to try to do everything we can to keep the AI in as much of our focus as possible on the audit side.
Yeah, I think, lots of super interesting points there. I think a lot of people know about like hallucinations, but I don't know that I've ever heard of that drift concept before. But it makes a lot of sense because, as with anything, as with like we evolve with time, right? And so keeping up with that evolution and making sure we're doing those checks, somebody's got to be responsible for that. And then, to your other point on the jobs and shifting, maybe that person that is accepting faxes and uploading them into our EHR right now, like maybe that job will be replaced by AI, but who's to say we couldn't train that person to go in and then audit what the AI tool is doing.
Right. And they're already a subject matter expert on that workflow, that data, right? And so that would be a good transition for them to say, hey, you're still going to be working with the same information. You're just going to be doing something different now. So instead of you actually scanning the faxes in and typing stuff in, you're going to go and make sure the AI is doing it correctly. Not everyone's going to be happy with that, right? And so, I mean, there's definitely going to be some churn and some attrition with it, but hopefully we are doing a good enough job with conversations like this and other forums that are happening that we are educating the younger generations enough to say, hey, I need to maybe think about learning about AI and majoring in that in college or something. So
Learn how to AI.
right.
Well, one thing we haven't really touched on is the patient experience. So let's talk a little bit about that. I mean, I increasingly have patients coming in and being like, so I looked up your treatment plan on ChatGPT and here's what it told me. Or I looked at my symptoms on ChatGPT and here's what it told me. So patients are using these tools increasingly. How do you feel like that is going to evolve in the future? Or like, how do you think patients, want to use these AI tools?
As our patients' generations change, oncology, generally speaking, is more of a 50-plus-year-old demographic, right? Thankfully, you don't generally get cancers until you're much older. But, as the 20 and 30-year-olds age and they start becoming the age where they are getting cancers, they're going to be much more tech savvy than our patients today, right? And so you're already seeing it, to your point, that where patients are coming in, I put all my stuff in ChatGPT and this is what it said, right? It's already happening. And these foundational models, the OpenAIs and the Anthropics, they sort of see the writing on the wall and they're already building health versions of their models, right? Where we're training it on healthcare data and all these journals and things that are out there. It is a very real, and I'm going to call it a risk for now. And maybe it's not a risk in the traditional sense of, legal risk or anything like that, but a risk from the standpoint of it's going to change the way I think that physicians have to think about how they practice medicine, how they talk to their patients, the assumptions that you probably have to make before you go into a room. Because today you probably already sort of think, well, I wonder if this patient's kind of tech savvy. I wonder if they've done anything that I don't have to answer questions to. But I think in 5 years, that's going to be a no brainer. Like, you're just gonna be like, every patient has done this, right? And so, and maybe that's a good thing. Maybe that, again, the rising waters raise all boats. I mean, the more that patients become involved and educated on their own care, I don't think there's any downside to that. There's definitely some adjustments that have to be made, right? And I do think, as the younger physicians are coming out of medical school and fellowship, they're going to be trained to be able to deal with those kind of nuances in care as well, right? The physicians who are in fellowship right now are probably already being trained, like, hey, your patients are going to come in with ChatGPT responses, and here's how you should do that. So I think it's a good thing. I do think there is, again, going back to the ethics side of it, I think ethics they go both ways. The patients need to be ethical as well, right? I mean, bringing in a recording device, hiding it in your pocket, not letting your physician know that you're recording the visit, that's not a great way to have a relationship with your physician, especially your oncologist. Yeah. So, I would ask patients to have the same courtesy with us that we have with them. Like, hey, I'd like to record my visit. Now, we are trying to help and standardize things by, like, right now we're looking at patient summaries. So using the scribe technology, we're already recording the visit instead of duplicating, data that's being collected and things like that. We're going to offer potentially a summary of the visit from that recording that the patient can take before they leave, right? And put it in language that patients can understand, right? Your note is in a medical professional's language, a physician's language. And if they read that note, they are not going to understand parts of the note probably. So can we give them a summary that is more patient focused and patient friendly? And so that's something we're looking at now. So it's going to happen. I don't think there's anything we can do to stop it. I'm hopeful that we can partner with our patients to make them feel comfortable. We want to be as transparent as we possibly can about the visits. I think the Cures Act has made that pretty clear across all of healthcare that they want transparency to patients. And I believe in this 100%. Patients should have access to 100% of their healthcare data. And I think everything that we are trying to do, we're trying to meet those standards. I mean, there's some technical limitations that have nothing to do with patients or physicians that we're working through, but I think that's what we want. I think it's what we all want. We all want the same thing. We want the patients to be educated. I think it's a great idea. And I'll just say I've done that for my family's healthcare stuff, right? To put it in Claude with an entire readout of another AI that, supposedly gives that kind of information and said, hey, does this sound right to you? And here's all the other details and just, to get, I guess, what you could call a second opinion. So yeah, I think it's good. It's definitely going to change the way we think as, an oncology industry or just healthcare in general, but I don't see it's going to happen. So we got to embrace it and make it the best we can. And at the end of the day, like I said, I think it's a good thing.
Yeah, I totally agree. I mean, I think transparency and trying to make like the patient experience better with these tools is a good thing. It's just being thoughtful about how we're using them. And then, like, to your prior point about the mistakes that AI can make, like making sure that, patients are aware that AI makes mistakes too.
That's right. So. That's right. Yeah. And I think, and that's a tough one too, because we understand that because we work in a world of risk, right? Like, malpractice insurance and having a legal team and all of that. But I don't know that patients, and I'm generalizing here, I don't know that the bulk of patients really understand what it means to manage risk. Yeah. And so when they pull up ChatGPT, there's disclaimers that says, AI can make a mistake or whatever. And just by using it, they're sort of accepting that as an end user license agreement, right? And so on your iPhone, when you open your iPhone for the first time, you've got this, 70-page end user license agreement. Knowing as everyone, exactly. They just say accept this, give me to my phone. So I do think that's, one of the challenges that, again, as patients hopefully become more tech savvy, they understand those risks. But I hope that patients, and hopefully we can help educate patients, when they start bringing in their printouts from Claude and they show it to you and you'll be like, this is actually pretty good. It did get this wrong. And so we can kind of help educate them to say, this is good and it got this and this right, but just, you need to know it's not always right and this is wrong here. And so, and it's not just our responsibility. I think it's the AI community's responsibility to educate patients that it's not 100% accurate, and it will continue to get more and more accurate, but 100% is the goal. Is it going to get there? I'm not sure. I hope so. Yeah.
Just one last thing on the patient experience. I'm interested, as somebody that's like on the supportive, I'm like interested in supportive care services and value-based care. Do you think there's a potential for like AI-powered navigators or like digital care companions, something to make? Because I think the cancer care experience right now, even when we're providing the best quality care we can possibly provide, it's a confusing experience, right? Yeah. And oftentimes like a little bit fragmented, especially in rural communities where patients are, getting their PCP care here and it's not in the same system as, their oncologist and everything like that. And so I think cancer care navigation is important, but it's also really manual and time consuming at the moment. So I'm just curious to hear your thoughts on that.
I definitely think so. Again, going back to the culture piece, I mean, as patients become more accepting of AI and talking to a voice agent and things like that, I definitely think things like what you're talking about. The companion piece is a really interesting one, and I'll give you just a little bit of a sad story real quick, and sad, not like boohoo sad, but sad like, oh, Larry, he's so sad. It's really funny because I often find myself, I have several different AI models I use, but I often find myself, depending on which one I'm talking to, OpenAI or ChatGPT or Claude, sort of talking to them like they're a person, almost just like to have a conversation, to talk something out. And there's something sort of like therapeutic about that, right? Like, and so I do see that as being very important for someone who lives alone, an elderly patient that lives alone and doesn't have a big support system. If there was an AI agent that could talk to them and check in on them daily, that's huge, right? And even if it just gives them someone to talk to and be able to have a back and forth conversation, I think there's a lot of value in that. So I do think that's a great idea from a supportive care standpoint. The navigation piece, I think we're already doing algorithmic runs and gap analysis and things like that on the data. And we're trying to identify patients, who could do palliative care or, psychiatry or psychology. So I think that navigation piece is helping. And we even have the ability to automatically send orders too, right? So like if you identify this patient would need lymphedema therapy, well, we can push that order to the lymphedema clinic and have them go ahead and call the patient set up. So I think that's happening already. Is it a navigator calling the patient and having that conversation again, that elderly patient that lives alone and checking on them? We're not there yet, but I think it's a great idea and probably something we should move towards.
All right. Well, I want to just think about the next few years in terms of where AI is going to go. I think we've alluded to a lot of potential applications for AI. But if you are advising, let's say, our CEO today, what does your roadmap look like for the next, maybe, let's say, 2 years?
So the provider first, I mean, that's definitely what I would tell any organizational leader, because I think that's your quickest, I hate to use cliche terms like low hanging fruit, but like if you don't have a scribe already, man, what a quick way to get a win with AI and to get providers like engaged and understanding how AI can change a workflow, right? So that I would say that workflow focus is 100%. When AI first came out, I think, again, going back to what I said at the very first of the podcast, we all had this vision of like, oh, AI is going to tell us to do this and make these decisions in medicine and this and this and this. That term called clinical decision support, right? A lot of these terms have been broadly opened up and people are putting things in these different buckets that maybe weren't the initial intention of the terms. But for clinical decision support specifically, in what I consider to be its true meaning of the AI is helping to make a decision, a clinical decision, right? And that's why it has that in there. I think we're a few years away from that. Again, going back to all those things I said before about legal and regulatory and comfort and culture, I think we're a few years away from that. But where we meaningfully see it making impact today is in the workflow space, right? And so I think would be the first place I would tell all CEOs to look. Like, what is it that you have happening today that is repetitive, that you're spending a ton of resources on, that is solely locked into a machine, that does not have physical hands that have to be involved in it? Those are the things that you can start looking at as quick wins, maybe seeing some return on investment, some ROI, right? Things like that. And again, ROI isn't always revenue or savings. Sometimes it's that quality of life, right? There is that piece of return on investment. So anyway, so all that to say that I think that focus on the near-term solutions that are going to make a huge impact today. Don't lose yourself in trying to wrap your head around clinical decision support and how is AI going to help my doctors make decisions now. Because the difference that how I see it is, when I have an overlay tool that's presenting a piece of data to you, like a path report, for example, they're lumping that into clinical decision support because the way they're sort of framing it is, oh, well, Dr. Baker needs to make a decision about this patient's cancer. They need to look at the pathology report to do that. So I'm going to present that. So I'm supporting that decision. And I don't agree with that. To me, it's clinical workflow support, right? They're supporting your workflow because you were going to go look at the pathology report anyway. They just took some clicks away from you. Yeah. They're not changing how you make a decision or what decision you make, right? Yeah. So I think clinical workflow support, extremely important. Again, make the clinician's experience better. It's going to improve everyone's experience. It's going to improve the front office experience. It's going to improve the patient experience. So I think that's a big one. And I do think figuring out how can you shift your culture to accept solutions. How can you make sure people aren't afraid of losing their jobs?
Yeah.
Setting up an infrastructure where the fax example you gave, I thought was a great one. That person who is manually putting the faxes in, AI can do that. But hey, we still have a job in the same area. It's just you're doing it on the back end instead of the front end, right? And so I think educating the staff and anyone who is fearful of losing their jobs that, hey, your job should be safe. It's just going to be different. So
I guess maybe as our last point, how do you make that culture shift? Like, what are the key change management principles that you've seen work within our organization and that potentially could be applied broadly across other practices?
Yeah, the biggest lesson I learned the hard way was trust. The moment you put a solution out there and it makes a mistake, all trust goes out the window, right? And I don't mean this to call anybody out, because I think this is just our nature as humans, especially if you're fearful that you're going to lose your job. Any small mistake becomes very sort of escalated and grand. And so I think being very diligent on the front end in your QA process of whatever the solution is, not just taking the out of the box solution that a vendor is offering you and turning it on and sort of seeing how it works. I think you need to go through a QA process. It's a little bit opposite of what most people think about from an agile standpoint, where you like fail forward. I think in a lot of ways, in a lot of areas, you can do that. But I think because of the trust factor with AI, it's difficult to do that, because failing is moving you backwards 100%, because you're losing that trust of the people, and trying to get that solution in is going to be difficult. So I think that's a big thing that we've got to try to figure out. And I think the other piece of it is getting people buy-in early. So I think what has really worked really good for us, and I'm going to pick on you for a minute. You've been a great advocate for me personally, right? Like, I can go to you and be like, Kate, I've got this new tool, where you try it for me. And so before I roll it out to all the physicians, I've got a small core group of physicians that you're a part of, that you try the tool. I have obviously a friendship with you. So you very candid feedback loop that we have. You're not going to hold back, Larry, this sucks. This doesn't work, right? And I need that though, right? I don't need for you guys to be, oh yeah, it's good. And then we end up rolling out, and the physicians, right, like I get all these hate emails and stuff. So yeah, so I think setting up champion groups like that, especially on the physician side, is so important. And I think that's one of the things that has made our last 2 years of rolling these solutions out successful, is because of physicians like you who are willing to come along and be the guinea pig and kind of have some of the heartburn along the way while we try to figure the solutions out. And I think you and the other ones in the group, you also have an understanding, and I'd like to make this a broader thing. And I try with talking to the physician groups and stuff of, there's a lot of potential here, but there's a lot of things we have to work through to get to the potential. And I think you and others have that understanding. So it's really nice to be able to give you sort of a little bit of a raw product and say, tell me how to make this better. Tell me how to make this fit you and your workflow. And I think that's really important. That's probably the most important, if anything.
Yeah, get the buy-in for sure. Well, thanks so much, Larry, for spending time talking with me about AI. I love talking about AI, and you know that I'll try out any AI tool. So look forward to continue to working with you on this.
Yeah, I know. Thank you. And thank you for doing this.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableOnc. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, and LinkedIn. BackTable is produced and hosted by myself, Kate Baker.
Our production team is led by Kieran Gannon,
Aaron Bowles,
John Reyes,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again, and see you next time.